Okay, let's speed up then. CDM finder, analysis, chronic disease finders. That's what you will see. So from that list already, you might be wondering what the hell. Because if you look at the actual CDM conditions, there are some in the finder that are not CDM conditions, right? So that's number one. Number two is this box. This box tells you a reason. So we have currently opened heart failure finder. You have my patients here as probable heart failure, and this is the reason for their probable heart failure. So they assume ischemic heart disease equals probable heart failure, right? Now, bear in mind that we have to separate our medical mind from IT mind. So it's not against Clan Williams, against Philippe. This is the spec they got, and they were told, this is the spec, do it. I told them, spec is stupid, don't do it. No, this is the spec, we have to do it, okay? So it's not their fault, so don't feel bad about them. They were told to do it. So this is from the spec. So this is your definite causes of heart failure. And those are your possible reasons for somebody to come on finder as heart failure, right? So you can see already that any heart attack, any angina, any ischemic heart disease, by spec, put a patient as a definite, so that it's called probable in finder, heart failure patient, okay? And that's essentially the evidence for that, right? So those are all patients with ischemic heart disease, with other things that were considered as a heart failure. So that's limitation number one, limitation by spec, meaning the finder was built as HSE requested that, although it doesn't really identify heart failure patients. You have a toggle here, I think, a patient type. So you can use it for any patients. Again, that was required by the spec. So if you like to go into, conspiracy theories, you might be started thinking, oh, why? And what's the potential second order consequence in future if they want that selection possible already? Similarly to those things, right? Or you can decide, well, I can identify my private patients who are technically worse off potentially now because they don't have medical card, although they're equally sick, and I can offer my own similar way of providing some sort of CDM program designed by the practice, run through practice reminders rather than through CDM dashboard, because they won't appear on dashboard, right? So that's heart failure. AFib finder, that's actually a good one. So if you never used CDM finder, that's the one to use first, because if you look at it, definite codes are actually definite, right? Unless you made a mistake with coding, unless you coded somebody as AFib and they're not. But essentially, that's a good one. The possible, you already see that you will pick up your DVTs, PEs here as false positives, and probably some heart failures as possible cases because of digoxin and some weird arrhythmias other than AFib as well, right? But in terms of the definite, so kind of probable cases on the finder, that's a good one. And we run through those patients, and we've identified some patients there that either we did not have an CDM at all, and the other one, and probably more annoying thing is, some were on CDM, but were enrolled in one, let's say for ischemic heart disease, but we never actually picked that also they have AFib, so we were short money for two conditions versus one condition. So that's potentially revenue generating things to run, right? Type 2 diabetes, important thing here, anytime. So that's again, your own clinical judgment. If Mary, who had HbA1c of 48 10 years ago, then she lost a lot of weight, started to introduce lifestyle changes, and now she has HbA1c of 42, 32 all the time, let's say, for last 5 years. is it a good medicine to say, oh, well, actually, you had diabetes, so let's get you in every 6 months? Or do we just accept, no, we just put it to the side, we take it next. But anyway, any patient who had A1C of 48 at any time will come as a possible case. So you need to be aware of that context to manually check it. Yeah, IFCC, yeah. But again, definite cases are reasonable, except of type 1s that might come up, right? So if type 1 comes up, they're not coming for CDM really. Now, asthma, definite cases, right? Looks reasonable. Looks reasonable, doesn't it? Yeah. The bad news is just part of the spec. Now, that's your possible cases now. Any of those drugs, essentially any patient with eczema is considered a possible asthma by the spec. Any of inhaled drugs prescribed ever. And now comes the best. Any of those drugs prescribed ever. That will come up as possible asthma COPD in the finder, okay? So again, that tells you that this is what the team got, this is what they built it around. If you think it's stupid, please email them it's stupid, because if there's more voices about it, that might create a change, because it wasn't enough for me to say it. But also you now know, if you decide to use the tool, what is it useful for? Was it useless for? Because if you were to weed out false positives here, I think it's just not worth your time. Because you have so many false positives, if you have to open each file, look for rationale, and then decide what you're doing with them, it just not works. For probable cases here, fair enough. The codes were okay, right? But for possible, I think just ignore them until that gets better. Now, another finder, atherosclerotic disease finder. Those are your conditions. And again, where do we have peripheral artery disease here, right? So if heavy ischemic heart disease, all right, we have CVA, we have TIA. Antiplatelets, probably, unless you have, that might be actually good exercise to do, because back in the day we put everybody on low dose aspirin, isn't it? And maybe knowing now what we know, we might be causing more harm by creating their GI bleeds rather than causing any benefit. So maybe going through those false positive would be good exercise as internal audit. Is this patient supposed to be on aspirin? But the one that will be false positive here for current program is peripheral artery disease, because it's not listed there. Chronic disease, chronic kidney disease finder, you can manually put your EGFR and then it'll give you a list. But then again, it's easy enough to do manual search with EGFR as the only criteria. And the kidney ICPC numbers, that's actually all right. Again, prevention programs for GDM preeclampsia, those are your codes. So again, reasonable codes. Drugs, again, probably mostly will be positive, meaning true positive. The only consideration is that drugs at any time and the program itself, they have to be diagnosed after 1st of January 23, right? So this is this timing here, that if a patient had preeclampsia, GDM in 2022, like they won't be accepted. The return for the prevention program won't be accepted.
But again, this CDM finder runs to whole patient, whole database.
Correct.
And suppose there is indifference of date of diagnosis, the date of coding, date of whatever item, and indifference of the patient status, even though they are in the CDM. What do we call it?
Well, you can play with it, so you will see what they're registered with in terms of CDM. Yes. Yes. Wait a second, because I broke something here. I can't see my mouse. Because it's different. I see what I broke. Okay, now I can see it. So if you're in your finders, you can select if you want somebody who's already on treatment program or somebody not on treatment program at all, right? Registered with some sort of structured CDM. Now, bear in mind that what I said about our AFibs, because in the dashboard you can see here already what the patient is registered with, what kind of CDM, right? But if they came up in your AFib finder, but you can see they're only registered with diabetes, this is your true positive, meaning that the reason they were found is they have AFib, however, they're registered only with diabetes. Does it make sense? So this is the patient when you are seeing them every 6 months and you paid for one condition, whereas you could have been paid for two conditions. Yeah? Oh yeah, there will be overlap, yeah. Yeah, there will be overlap, like that.
Women, female.
Yes.
So they will only pick the supported female. They will not pick the supported unknown.
Yeah, hopefully. Are you able to make an unknown patient pregnant though? No, I don't know. I never tried. So if you have a mistake, yeah. Okay, so were you able to create a obstetric consultation for? Oh, were you? Okay, all right. Okay. Because that will, you know, put separated again, separated brains, putting medical brain, putting IT brain. From IT perspective, you would think your flow of logic would be to do antenatal kind of visit that has to be female, right? No, you're checking it. Okay. Yeah. At risk undiagnosed. So this is your OCF. So there's a lot of things. This is your mental health, your hypertension, your obesity, a lot of things here. And in terms of numbers, who would be picked up by the potential OCF? Any of those things coded, they would come up as potentially OCF case. So if you were bored, if you had nothing to do and you decided you want to get as many OCF as possible, that list will create list of those patients if you decided to get them in. It does allow you. Okay. You're ahead then, yeah? But then will the... You have sex here, right? Yeah. I don't know the honest answer because I didn't have this probably rare enough case, so I didn't test it. But test it and see. Test it and we'll know. So in terms of what can we do with false positives then, right? There is an option to snooze them, to put them to sleep in a way. So if you have your list and you decided somebody is false positive, if you right click on this entry and you hit exclude patient, you will have option to exclude them for whatever reason over a certain time. There was a bit of discussion, should we just remove them or should we snooze them? But realistically, you know, they are likely to develop something eventually, not to be very pessimistic, but they are likely to develop some CDM conditions. So if you would snooze them forever, then they would have never come up to your finder, right? If you want to do it, I know, as exercise once a year, once every 6 months, whatever you decide to be your policy, you can keep them to, you can remove them temporarily from the finder. That's my comment for CDM4. I had I've heard so many versions of why it wasn't started that I don't believe any of them. So I'm not able to tell you why. There was a lot of work, there was a lot of time pressure, there was a version ready to be deployed, and then it was pulled, not to be deployed. And that's one of the reasons why some bugs, fixes came with delay, because they were fixed in the version that we were working on CDM4, and then we had to fork to two versions, the CDM3 and CDM4. So CDM4 is in the freezer waiting to be potentially brought back. And like the error code for I think that's Dublin practices, you need it for your GMS, sorry, not GMS, HSE childhood vaccination returns. They insisted to have error codes within them, and some people were writing by hand. So now you can add that to your returns automatically. But again, the reason for delay was it was frozen with the CDM4. It had been fixed before but not deployed. So this is what is, if or when the CDM4 is started, those are the conditions that would come to the new CDM. So you already have answer what the hell with the finder, why the finder does not match CDM conditions, because the plan was that it will match. So it was made ahead before the CDM4 was released. So your chronic kidney disease and your peripheral artery disease will be with CDM. In terms of prevention program, you have other CDMs. You have familiar hypercholesterolemia and you have valvular heart disease with age 18 plus for those. New things in OCF. So with that's really what would come there. The biggest change would be they wanted to have this Dutch lipid score built in for somebody who have high lipids, and that would include imputed LDL calculator, meaning if somebody's already on some drugs to bring their cholesterol down, there is a formula that depending what drug, what dose, and what's your cholesterol on this drug, we estimate that your cholesterol without any drugs would have been this. And that then feeds it to the Dutch lipid score, and that tells you, is it likely that you have actually familiar hypercholesterolemia or not. So those are the changes. So it's not like Health One only was pulled. It was pulled across the country. So meaning CDM4 was not started. So no software currently has it because there is some ongoing discussion about conditions, about rules, about I don't know. I'm not. You said that. I also say if you don't know what is it about, it's about money of some sort. But yeah, objectively, CDM4 really is ready to be deployed for Health One. We just need green light, and there shouldn't be any delays then. Unless, sorry, that's wrong statement. Unless the agreed green light is green light, but we are changing A, B, C, D, E, then we have to implement those changes before we can deploy it. Yeah. Any other questions, comments about CDM4 or no? You're happy? Happy.